Welcome back, critical care fellows and trainees. I'm incredibly excited you're joining us for this explainer. Today, we're putting a laser focus on a high-yield, purely clinical topic that literally every intensivist needs to have down cold, both for the fellowship exams and for daily practice. We're talking about the universal clinical protocols for brainstem death certification. We're going to break down the exact cognitive steps you need right at the bedside using a highly structured visual approach. So let's just dive right in. Okay, so here's our roadmap. We'll be looking at a top-down clinical algorithm, moving through the clinical prerequisites, excluding confounders, mapping out the brainstem reflexes, and then the execution and interpretation of the apnea test. Finally, we'll wrap up with the Lazarus reflex. All right, starting with Section 1, the clinical prerequisites, or the non-negotiable bedside setup. Now, these right here are your absolute, non-negotiable prerequisites. Honestly, if your patient doesn't meet these perfectly, you literally cannot proceed with any testing. You absolutely need an established, irreversible cause of coma, resulting in a Glasgow coma score of exactly 3. You also have to see catastrophic brain injury proven on imaging, and you've got to completely exclude all confounding factors. And remember, all of this has to be happening in the context of absolute hemodynamic stability. Even if you're having to push high doses of vasopressors to keep them stable, that stability is a must. As you look at this, you'll see the imaging has to leave absolutely no room for the brain to expand. You are looking for definitive, completely unsalvageable damage. Think of it like a tightly packed box, like a Marshall grade 6 CT scan, where those basal cisterns are just totally effaced and the ventricles are compressed closed. Without this crystal clear radiological proof of a catastrophic injury, you simply cannot make the diagnosis. Moving right along to Section 2, excluding the confounders and identifying physiological mimics. You know, in the ICU, something as simple as correcting a patient's blood sugar or their sodium can sometimes completely turn their GCS around. So for your boards, and honestly just for being a good clinician at the bedside, pay very close attention to these exact numerical boundaries. Before you even think about proceeding, that PaSCO2 needs to be sitting between 35 and 45. PaO2 has to be greater than 60, blood glucose firmly in that 80 to 200 range, and serum sodium tightly controlled between 135 and 155. If you haven't corrected these, you cannot proceed to clinical testing, period. Okay, let's talk about the magic number here, 5. You have got to wait at least 5 half-lives for all those sedatives, opioids, and neuromuscular blocking agents to completely wash out of the patient's system. Think about it. If a patient was on a prolonged midazolam or thiopentone drip, and especially if they were hypothermic, which really slows down clearance, you might be waiting 48 hours or even more. You never want to rush this step. I know waiting out those 5 half-lives takes immense patience. Sometimes it feels like waiting for a callback from the ER, right? But residual drugs are absolutely the #1 pitfall when it comes to premature testing. All right, on to Section 3, mapping brainstem reflexes, our neuroanatomical journey. Now, if you just memorize this top-down structure, you are never going to get lost at the bedside. We're going to systematically test specific cranial nerves, moving strictly top to bottom through the 3 parts of the brainstem. We start at the midbrain at the top, move down to the pons in the middle, and finish at the medulla at the very bottom. Think of this as your spatial anchoring. When you shine a light in the eye for the pupillary reflex, the optic nerve takes that signal in, and the oculomotor nerve brings it out. That specific loop purely tests the midbrain. Moving down the ladder, when you brush the cornea with cotton, those cranial nerves 5 and 7 are testing the pons. And for the doll's eye or the cold caloric test, where you instill ice water into the ear, you're sending signals via cranial nerve 8 straight through the pons, and you're checking for ocular movement via nerves 6 and 3. By doing these, you have systematically knocked out midbrain and pontine function. And finally, we hit the medulla, the absolute lowest anatomical structure of the brainstem, by touching the posterior pharyngeal wall to test that gag reflex via cranial nerves 9 and 10, or by passing a suction catheter down to the carina to test the cough reflex via cranial nerve 10, you are verifying that these lowest anatomical reflexes are completely gone. Once you've mapped this total, complete absence of function from top to bottom, you're finally ready for the ultimate physiological test. Which brings us to Section 4, apnea test execution, the ultimate physiological stress test. So, the whole point of the apnea test is to let the carbon dioxide rise high enough to trigger a breath. You'll want to memorize this exact clinical flow. First, pre-oxygenate the patient with 100% oxygen for a solid 2 minutes to prevent any desaturation. Next, disconnect the ventilator and immediately place a tracheal catheter to insufflate oxygen at 6 liters per minute. Now, here's an absolutely vital safety tip. Make sure your insufflation catheter occupies less than 70% of the tracheal lumen. If it's too big, the air literally can't escape, and you're going to cause a massive pneumothorax. Once that's set up, you carefully observe the patient's chest for 8 to 10 minutes. Keep in mind, during this entire test, you are still the physiological guardian of this patient. If you see even the slightest flicker of a spontaneous respiratory effort, the brainstem is not dead. Abort the test right then and there. Furthermore, if hemodynamics collapse, if the blood pressure starts to tank, or if you see severe oxygen desaturation during those 10 minutes, you must abort the test immediately. Stabilize the patient, reconnect the ventilator, and you can always try again later once they're restabilized. Moving on to Section 5. Apnea test interpretation, or reading the blood gas. Okay, so after 10 minutes of apnea, you go ahead and draw the arterial blood gas. But what exact numbers are you actually looking for to confirm the diagnosis? This right here is incredibly high yield for your fellowship exams. Notice the two distinct targets we have laid out here. It's absolutely critical to realize that both of these conditions have to be met for a positive test. The absolute PaO2 must be 60 or higher, and it has to have risen by at least 20 from the patient's baseline. Let me give you an example. Say you have a COPD patient whose baseline CO2 is already high, sitting at around 55, and it rises to 65 during the test. Well, that test is negative. Why? Because even though it crossed the 60 mark, the rise was only 10, not 20. It would actually need to hit 75 to be positive. You really have to hit both targets to definitively prove that the respiratory center is totally unresponsive. And that brings us to our final section, Section 6, the Lazarus reflex, a vital clinical pitfall. Imagine this. During your examination, you touch the patient's leg, and suddenly you see the limb spontaneously pull upward in a triple flexion movement at the hip, knee, and ankle. This is the Lazarus reflex, and it can be terrifying for families. But you have to know that just because a limb flexes, it absolutely does not mean the brain is alive. This is an entirely local spinal cord arc, totally independent of the dead brainstem above it. It's actually pretty common, especially in younger patients. Keeping this local spinal reflex in mind and proactively counseling families about it is going to make you a remarkably capable and compassionate intensivist. So I'll leave you with this final thought. In an era where machines can mimic the breath and pulse of life indefinitely, your ability to definitively and accurately diagnose death is what ultimately protects human dignity. So, are your bedside exam skills sharp enough to bear that responsibility? Keep reviewing these protocols, and we'll catch you in the next explainer.